Professor Åsa Hammar. Insert again. Today I take pleasure in welcoming our visiting Professor Åsa Hammar, who presented in 2020 when she shared profound research on whether impaired memory after ECT is true or false. A bit of background history. Professor Hammar is a professor of clinical neuropsychology at the University of Bergen in Norway and Lund University in Sweden. And she's part of the Department of Biological and Medical Psychology. Her research focus is on mental health from a neurocognitive perspective. The research program employs a range of design methodologies and as well as a diverse set of research techniques, which include, but not limited to, neuropsychological assessments. Working alongside national and international collaborators, Dr. Hammar and her research group strive to enhance the current understanding of neurocognitive and emotional processing in mental health. Professor Hammar is currently presenting from Valkenburg in room 26 and welcomes any face-to-face engagement after the lecture. I'd also like to take this opportunity to thank my colleague Kamal Kamaluddin, who have arranged for Professor Hammar and who will facilitate the discussion later. Today's topic is, are we giving enough attention to cognitive dimensions of serious mental illness? What are the implications for diagnosis, treatment, and relapse? I welcome Dr. Hammar.
Thank you so much for the introduction. Just get the sound problem. Yeah. So thank you for having me here at Valkenburg and in Cape Town. It's always lovely to be here, and thank you for inviting me for this lecture, which I think is has a really important topic. Yeah, I don't think I have the possibility to put. Technical problems. The presenting. So you're up now on the, yeah, it's okay. Okay, let's go. So yeah, I'm going to talk about the cognitive dimensions of serious mental illnesses, and I'm going to present some clinical perspective as well as empirical, more research perspectives. My agenda is to just first explain a little bit about the definitions of neurocognitive functions, or cognitive functioning, and how we as clinical neuropsychologists define this concept and more, and say something about how we can assess cognitive functioning and how it affects different mental disorders as schizophrenia and major depressive disorder. And finally, I'm going to show you some research for interventions targeting cognitive functions. And I hope that we all can discuss some future perspectives in this topic and area. Just to say something about cognitive functioning, that's a composite concept where we have included a lot of different levels and aspects And often in the literature, we refer to cognitive function as one composite concept, and often conclude that MDD is associated with cognitive dysfunction, or it is not associated with cognitive function. That's why we find the literature so divergent, and when we try to look into that it is might be important to explain the concepts even more. And often we have a second level of concepts where we on a domain level defined cognitive functioning. And the big ones here I present in my model is memory, executive functioning, and attention. But again, these concepts are include a lot of different aspects which we measure with our neuropsychological assessment. So for example, in memory, we can measure visual memory as well as verbal memory. We look at different aspects. If people have memory problems, is the memory problem within the learning aspect, or in the recall, or in the recognition aspect when in memory. And often we have patients coming to us complaining about memory problems. They're worried that they have developed dementia, for example, and so on. And when we do the measuring, just in the memory domain, we might find out that they perform equally to their norm group, to others in their age. And actually, when we do the more comprehensive assessment, neuropsychology assessment, we see that the problem lies in an attention problem. As you know, in order to remember stuff, you have to learn stuff, you have to have the attention first in place. So and as well as within the domain of executive functions, we measure very many different aspects. And if we do composite scores of all those different aspects, we might miss one of the impaired aspects, actually, which ones the patients complain of. So it's important to also have the aspect level when we define neurocognitive or cognitive functioning in our disorders. And how we assess cognitive function, we can do that in several ways. We do the neuropsychological testing with standardized tests. Often have an EQ test first to just measure which expectance level we should expect our patients to perform in. And then we do the neuropsychological test, measuring different aspects of these domains. And we can also do self-report tests that have actually lately been more and more used in our clinic, in our research projects, where the patients or the participants by self-reports report their cognitive functioning, especially in daily life, or we can have peer reviews. But as we all know, cognitive dysfunction, it affects very many areas of life, not at least daily life functioning, work and academic performance. It also affects your relations, your next of kin, your relations to them, as well as social functioning. And one aspect is also the emotional processing, how, with some examples I'm going to show you later. And we also know that this affects quality of life. So, and then in the next level, all these areas has impact over treatment and treatment outcomes, as well as risk for relapses and so on. I'm going to talk a little bit about schizophrenia as a cognitive illness. And about 10 years ago, this was really a question that started to be debated of Keefe, who just addressed that it was time for change of focus. And this change of focus when it comes to cognitive illness and schizophrenia could be illustrated just in this graph we're showing how many publications registered in the PubMed has increased lately, as an where you combine cognitive impairment and schizophrenia. So it has had increased focus, and a lot of studies show that many of this patient group experience cognitive impairment. Here, and this slide shows that nearly 98% all patients exhibit cognitive impairment relative to expected cognitive performance. Here we had they have done by expectation score by maternal education years, and we can see that the expectation in the patients and therefore is not reached to the expectations levels of cognitive performance compared to normal controls. Cognitive impairment in schizophrenia is quite serious because we know that the average IQ is about 85, about 1 standard deviation from the normal compared to the normal population, which is 100, as you know. And especially test measuring attention, learning, and memory shows about 1 to 2 standard deviations below average. And we only have 20 to 25% of this patient group have average scores. So it is a serious illness when it comes to cognitive functioning, and if we compare them with the normative data, we can see that this is a test battery called Ray-Bands. It's a very short test battery that we often use when we assess this patient group. It's about 20 to 30 minutes long only. And it's repeatable, and you can see that the scores compared to normative is quite below. And one of my PhD students, he defended his thesis a year ago. We were working just with this Ray-Bands test battery. He had assessed a lot of patients in the clinic, several hundred, and we collaborated with our colleague Grant Iverson at Harvard, who acted as co-supervisor for Rune Rødberg, my PhD student. And what he was looking, he was focusing both the usefulness and the accuracy of this neuropsychological method, and especially the importance of having normative data from the actual patient group. So you're not compared, your results is not compared only with healthy controls, but also compared to your diagnostic group. So you can also judge the performance from what's expected when you have schizophrenia. And this is in Norway, the director of health have mean that everyone affected by schizophrenia should receive offer of a measure of cognitive difficulties. So the focus has increased on these on the cognitive aspects. And there is also a focus, and several models have been made and published in order to explain the negative symptoms of schizophrenia and the cognitive deficits and the nature of the relationship. Some of a colleague group in Norway have conducted actually a 10-year follow-up looking at the cognitive composite scores for 10 years, dividing into groups of severity of negative symptoms, healthy controls and those with no negative symptoms, mild and to sustained. And they find that there is a significant effect of both group and time, and that the group with negative symptoms show poorer cognitive functioning. So we have a dose effect relationship between the negative symptoms and cognitive difficulties. They also show that the global functioning developed over these 10 years in this patient group, but also there is a relation between the negative symptoms in the patient group with lower functionality compared to those with no negative symptoms. So to conclude, cognitive difficulties and negative symptoms are common in this disorder. About 80% have cognitive difficulties, when about 50% have negative symptoms. And there is a reason to believe that the cause is same, but there is still two distinct phenomena which overlap and co-vary to a certain extent. So I'm going to say something about now major depressive disorder. That's the main focus area I have had in my research and in my clinical experience. And it is a very heterogenic illness, as most of you know, and with a very high prevalence. The lifetime prevalence is often reported between 15 and 25%. At any time, there is 5% of the population in at least in Scandinavia that needs treatment for major depression. We also know that it's twofold gender difference with twice as many females getting this diagnosis. And the most serious thing which I am interested in when it comes to cognitive dysfunctions is the high relapse risk. We know that patients that have been diagnosed for the first time with major depressive disorder, there is a 50% risk that they will, within the 2 first years, have a new episode of depression. And if you have had 3 episodes, it's about 90% risk to have a recurrent episode. So it's quite serious. And how much is this related to cognitive dysfunction? That has been one of my main research topics. And it costs a lot to be depressed. It costs a lot for of course, for the individual, for the family, but also for the society. And in at least in Scandinavia, the highest costs are related to societal production loss, that people are not in work and not producing what they are supposed to do. That the cost when it comes to treatment is only about 13%. The rest of the cost is loss of production. people not filling the studies, the academic work or in work. When we look at the diagnostic criteria, we can divide them into more emotional symptoms, biological symptoms, and there is a few cognitive symptoms also in the diagnostic criteria. But when we treat and we target, when we treat, our treatments are often are mostly targeting the emotional or the biological treatments, more or less the cognitive symptoms. And when I say that, I don't think about the CBT treatment, which is also targeting, it's targeting or not functioning thought patterns, but the outcome, the treatment outcome is diminished emotional symptoms and biological symptoms, and not targeting the cognitive capacity or the cognitive impairment per se. So and the focus on cognitive residual symptoms, depressive depressive residual symptoms. This is a presentation of depressive symptoms over a 3-year period, where the yellow line represents the cognitive symptoms as compared to the red line, where we have the mood symptoms in depression. So one of the research area I've been working with is these cognitive residual symptoms that patients have, even though you have treated the mood symptoms. And we know that when you are depressed, and when I started to work with this several decades ago, everybody accepted that when you're in the symptomatic phase, in the acute phase of depression, you have cognitive dysfunctions. But most clinicians, and they told their patient and expected their patient to normalize parallel to the mood symptoms were treated. But so many patients experienced that when they were not depressed anymore, they still had something was changed, and it was quite diffuse what this change was, but now lately more and more empirical evidence show that these cognitive deficits are still present in the remitted phase, and that it worsens with repeated episodes. So me and my research groups and international colleagues, we have focused on this in several large main studies and longitudinal studies, assessing the patients with neuropsychological tests. We have used experimental paradigms, we have used fMRI and cortisol measures, self-report measures, and lately, actually, we have done some qualitative interviews, interviewing patients how they experience these cognitive residual symptoms. And the main question was to see what's the neurocognitive profiles in major depressive, and what impact does it have on clinical perspectives. And development of cognitive functioning in depression. There is one state hypothesis, which is the one that traditionally we met. This will normalize when you improve hypothesis, suggesting that being depressed is neurotoxic, that it affects it's toxic for the brain, and duration here is a really important aspect, because we see in a lot of studies the duration of depression is correlated to cognitive impairment. And then you have the trait perspective or hypothesis, which is more like you have a vulnerability for developing, if you have a neurocognitive vulnerability, so you have you're more likely to develop a depressive episode if you are experience tough life events and so on. And we were looking into this with our data, doing our experiments and our studies. We actually had support for all these three perspectives in our results. And when you look into the literature, you can also see that you find support for all these, but there is no actually no clear still we don't have a clear picture of which cognitive aspects or cognitive functions related to these different perspectives. So we conclude that since it's such a heterogeneous disorder with so many subgroups and first episode patients, recurrent patients, I think we have to be more look into both the aspect levels and subgroup levels with this to achieve a more clear picture. But one thing we know is that the SCARP perspective hypothesis is related to duration. So we can see that differences between first episode patient when it comes to verbal memory. We look into the HPA axis and we look at more neural correlates. There is a very it's very evident that duration of depression is causing cognitive impairments. We often also talk about hot cognition and cold cognition, and the cold cognition is the more areas that we have in the prefrontal cortex and regulates both behavior and thoughts and feelings. But in more the hot cognition is more the emotional processing in the more subcortical areas. And we also know that the depression is associated to abnormal emotional processing. And what we did in an experimental study, this is one of my PhD students. He's gonna defend his thesis next week. Actually, his name is Eivin. We did in collaboration with Jutta Jorman at Yale University. She acted as co-supervisor for him. We used one of her paradigms with faces and sad and happy faces in a paradigm which we combined with working memory. So there were 4 conditions. There were happy, sad faces, but there was also 2 cognitive conditions with less effort and more effort in a working memory paradigm. And what we actually found here was that when, and these patients were a 5-year follow-up from the first episode group, so they were not depressed anymore, but we could still see differences between healthy controls and these patients at the 5-year follow-up when it came to emotional processing. Because when the the face was sad, there were negative stimuli of the the stimuli, negative, and it was combined with a more effortful cognitive task, we could see that they differed from the healthy controls still when they were not depressed anymore. And you can imagine this could be very vulnerable if you are supposed to do a cognitive task and there is something negative associated to that. It's more effortful for this patient group compared to an easy and less effortful cognitive task where they did equal to the healthy controls. And this was actually this negative and working load condition was related to rumination, and it was related to relapse risk. So it is important to target this cognitive deficits that's evident still after 5 years and when they are not depressed anymore. So that was the next question in our research group. How can we target these cognitive residual symptoms? Is it possible to do something, to do an intervention in order to increase cognitive capacity? And will that have any effect on the relapse risk or in treatment outcome? And there is actually a method called cognitive remediation. And my experience is that not many, even though you are in healthcare, really knows what's included in cognitive remediation and what we mean with cognitive remediation. And it's not an intuitive concept for the patients, the relatives, or for healthcare personnel. I will come back to that. But in cognitive remediation, it's 3 main things that we have to do. It's psychoeducation, telling about the patients that a lot of others experience these cognitive deficits. It's the strategies. It's important to develop different strategies to compensate for your cognitive deficits, and cognitive training is also something we're trying to find cognitive training. And the most important thing is that it has to be a generalization to everyday life, because you can practice and train on a cognitive task, and you can be really good at that, and you can increase speed and accuracy and everything. But if it doesn't have this transfer effect to daily life functioning, then it won't have the effect we're wanting to have. And when it comes to cognitive remediation in schizophrenia, this has been the last decades, we have increased so much research in schizophrenia and cognitive remediation, and a lot of publication and a big research community actually. So when I started to look into this with cognitive remediation in depression, there was only a handful of publication about 10 years ago, and all these cognitive remediation for MDD was targeting the mood symptoms in order to get the mood symptoms better. And my focus was to get the cognitive capacity enhanced instead. Actually, I was lucky to meet the colleague at Berkeley, Sherry Johnson, and we were talking about this cognitive remediation project for depression, and we fortunate to receive funding at the Berkeley Foundation, Peter Satter Foundation, which made it possible for us to gather researchers from globally and to discuss this with cognitive and affective remediation. And actually, we have now a society called CART, where we address these questions and do different types of research projects. And actually, we suggested to change cognitive remediation to cognitive enhancement therapy for depression, and published is a letter, debate article, and we did receive very many interesting comments, mostly opposed to the cognitive remediation cognitive remediation concept, but cognitive enhancement therapy could be more intuitive for healthcare personnel to understand what it is. And we did some, in this group, we did some piloting to just start with. We focused on computerized cognitive training, focusing on working memory, actually developed for ADHD disorders, and this is a 5-week, 5 days a week, and 30 to 40 minutes intervention. And we did pre and post testing with a neuropsychological test battery, and finding shows that those and these were the patients included here were remitted from depression. So it was when they were treated for depression with the ordinary therapy or treatment, they were included in this project. And we saw that those that had responded for working memory, and it was enhanced after the intervention, this was related to lowered rumination and enhanced working memory capacities. Actually, we also tested our patients with pre and post with this experimental paradigm, and after the intervention, the relationship between the negative and high load working memory condition disappeared actually, and rumination was lowered. So it indicates that the cognitive remediation training can have some impact on rumination and cognitive functioning. So we wanted to develop this because we only had the cognitive training aspect in this first pilot. So we developed a new digital intervention targeting cognitive residual symptoms after major depression, and this is also a 5-week intervention. It's done on the internet, and with different modules, including psychoeducation, strategy developing, and some cognitive training, and they were followed by a coach once a week. And this January, one of my PhD students, Sunniva Myklebust, she defended her thesis on this intervention. And what we saw with self-report test was that the cognitive functioning did increase pre-post test, and it was stable at 6 months follow-up as well. And so as well was self-reported rumination. And what we saw as predictors for the outcome here was duration, especially, and the belief in the intervention, and but duration was a significant predictor. If you had more than 1 year experience of being depressed, you had not a successful outcome. And we have actually 2-year follow-up data now, and showing that the effect on both self-reported rumination and cognitive functioning was stable also after 2 years. But here it was interesting to divide between those, as we said, 50% would have at least a relapse. Many of these patients also was not first episode patients. So what we expected was that at least 50% of the 2-year follow-up would have done experienced a relapse. But in our data, 40% had a relapse and 60% no relapse. And then we divided between the groups in our analysis to see those with relapse and those with no relapse, where they differed. And we can see that the both rumination and cognitive impairment differed significantly within these groups, and those that was not responding, even though low scores of depression symptoms after the post intervention, we could still there was a significant pre-post in the group that didn't have a relapse of depression symptoms. So what we can here conclude is that the patients, we have done, as I said, also qualitative interviews. They report cognitive residual symptoms and that these affect everyday life functioning. That there is an increase for a new episode, and that we can target and tailor this with intervention. This intervention I showed you was both targeting cognitive remediation, cognitive residual symptoms, but it was also tailored, so all the participants could tailor what focus they needed and wanted to have in the intervention. So the connection here with neurocognitive difficulties in everyday life, leading to coping problems, negative thinking, negative self-representation, will have the possibility, the risk for increasing the risk for relapse and recurrent episode. So developing digital interventions for cognitive remediation that's targeted and tailored will eventually increase the cognitive capacity, and then have the potential to decrease risk for relapse and recurrent episodes. And actually, we did now in the middle of an RCT with this preliminary data. We have a waiting list group within this intervention, where we see that the intervention group has a significant improvement in self-reported cognitive functioning compared to the waiting list group. While the depression symptoms there is no change. So we have some promising data here, and looking forward for the 2-year follow-up data as well. So lastly, I just want to mention all my colleagues around the world, not least all these my former and current PhD students here in bold, and I would like to thank you for your attention. Okay.
That's my computer to go off.
This is the end.
Hi, everybody. Trust my computer to go off at the end. But I just want to thank Prof. Hammar for your stimulating and interesting talk. I'm sure it's raising many questions. If we have about 10 to 12 people in the room as well. So I will be fielding questions from the chat as well as from the room. If there are questions in the room, I will repeat the questions as we go forward. Thanks.
Should we end the slideshow? No. There we go.
Okay.